I think we have to move on the last one. So it will be a presentation from Asif Khan Setu from Cologne. And I think that Asif will speak about a new technique, imaging techniques in dry eye disease. And the supervisor is Philip Steven.
Good afternoon, everyone. I am Asif Khan Setu from University Hospital of Cologne. Today I'm going to talk about my PhD topic, what I have done last 3 years, development of novel diagnostic tools for dry eye disease using various clinical devices such as infrared meibography, optical coherence tomography, and confocal microscopy. I think today all of you heard a lot about what is dry eye disease, so I'm not going to tell what is dry eye disease. So from a very brief, it is a multifactorial disease where the tear frame instability, ocular surface inflammation, and neurosensory abnormalities play an etiological roles. And some key signs are alternation of Meibomian glands, which is from the Meibomian gland dysfunction disease, ocular surface inflammation and damage, and neurosensory abnormalities. To diagnosis the dry eye disease, we have several imaging modalities in the clinic, such as infrared meibography, optical coherence tomography, and in vivo confocal microscopy. So this is the example of the in vivo confocal microscopy, and this is the infrared meibography, and the lower two devices are the optical coherence tomography, which is clinically routinely used to diagnosis dry eye disease and other ocular surface disease on both the posterior segment of the disease maybe. So when I started 3 years back, so we have some limitations or unmet needs in the clinics, what we need to do or what is missing in the clinics. So we found that there is a missing or lack of some image analysis softwares. The clinicians or the gradings use the manual or semi-quantitative analysis to analyze the lot volume of images produced in the clinics. And due to the manual or semi-quantitative image analysis, it takes a significant amount of time to analyze the large volume of clinical data sets. And due to the manual image analysis, we have a high variability and low repeatability. And there is a lack of clinically validated imaging-based biomarkers using the large data sets. So we hypothesize our project as automatic image analysis could enable a faster disease diagnosis, which could be used as potential image-based biomarkers for best possible therapy. So for my first project in Meibomian gland imaging, infrared meibography is a non-invasive and a very well-established imaging methods which routinely used in clinics to image and analyze Meibomian glands for both upper and lower eyelids. From the example, you could see this is the example of the healthy eyelids where all the Meibomian glands are presented in both upper and lower eyelids. And here is the example of diseased eyelid where the Meibomian glands are completely lost, or almost 2/3 of gland are already lost. So in the clinics, the clinicians needs to analyze how many glands are lost, how the tortuosity is changed, and the weight and the length is changed in this kind of images. That's why we came up with an idea to use the artificial intelligence to segment all of these images and to build novel methods of using the artificial intelligence. We collected clinical images from the University of Cologne eye hospitals. From there, you could see we have collected images of both upper and lower eyelids of the disease images. And there are almost 700 images we collected, and we manually annotated all of the images. And before the model training, we have verified all of these images by ophthalmologists and clinicians. And we trained our artificial intelligence model to identify or predict the Meibomian glands. And we tested our models on the 50 upper and 50 lower images, and our model gives a very high accuracy, which is 96%. And after the segmentation of the Meibomian glands, we provide the further quantification, such as how many number of glands are presented of the segmented images, mean gland width, gland pixel, and the tortuosity. And we believe all of this information are highly correlated with the disease diagnosis. And we also make a correlation how our automatic segmentation perform with the manual ground truth annotation. And from there, you could see our automatic segmentation is really close to the ground truth Meibomian gland segmentation in both number of glands, mean gland length, mean gland width, and the tortuosity. And for there, we are really confident to further clinically validated our softwares in the future. Here is another project that involved in imaging of corneal nerves and immune cells. Confocal microscopy is another non-invasive and laser optical imaging techniques and routinely used in clinics to analyze various kinds of corneal research, such as corneal nerves, dendritic cells, acanthamoeba, keratocyte, bacteria, and fungi. Here is an example of a very healthy eyelids, not the cornea, where the lots of corneal nerves. And the last two, you could see a disease cornea, where the loss of corneal nerves and a very high immune cells or dendritic cells, which is very large. And also to identify the nerve loss and to generate the number of the dendritic cells presented in the disease eye, we develop another deep learning model to segment the corneal nerves first. And for this reason, we collected almost 1,000 images from the cornea, and we also manually annotated the ground truth images. This is the ground truth images. And before the model training, we validate all of the images by the ophthalmologists and clinicians. And after the model training, we test our model performance, and it gives us very high accuracy, sensitivity, and specificity based on the prediction of the corneal nerves. Same as the Meibomian gland segmentation, we further quantify the segmented images and provide the quantification parameter of the segmented images, like how many nerves are presented on the segmented images. Like in here, you could see the total number of the nerves, total number of length, branching points, and tortuosity. And from the correlation of our performance of the model on the test data set, you could see compared to the manual annotation, our model predicted really close in terms of all quantification parameter, like corneal nerve fiber number, length, branching points, and tortuosity. Furthermore, we also developed another model to quantify the dendritic cells. For that reason, we collected the images from the University Hospital Cologne, and we collected almost 800 images from the disease eye. And we train a model to predict the dendritic cells. And here is an example. You could see our model shows how many cells are predicted and their density. Same as the previous two, Meibomian glands and corneal nerves. We further classify the dendritic cells, and we try to establish categorize the dendritic cells into 3 categories based on the length and the dendrites. And we categorize them into 3, like the immature cells, transition stage cells, and mature cells. And the classification is based on the length and the dendrites. So if the length is less than 50 micrometer and without dendrites, we consider it the immature cells. And if the length is more than 50 micrometer, it is the mature cells, and in between, we consider it is the transition stage cells. We classified more than 1,000 cells in the test data set, and we plot based on the length. When we plotted all the segmented cells in the plot based on the length, you could see a very scattered plot of the length of the dendritic cells segmented of our test data set. And you could see no differences based on this length, or we could not differentiate only based on length. like how much cell is mature and immature on the transition stage. Then we put a threshold, like 50 micrometer to differentiate the activated and non-activated, like the mature and immature cells. And the threshold is like 50 micrometer. And after that, we think there might be a time point where some cells going in from immature to mature stage. So that's why we come up with an idea to put another threshold or another criteria such as branching points together with the length in the immature cells. Then we found a transition stage cells. So this transition stage cells is same as the immature cells, like less than 50 micrometer, but it has started some branching points. So that's why we categorize into three category of the immune cells, like the immature, transition stage, and the mature cells. Then we move further on the Meibomian gland segmentation. Though we already know that the Meibomian gland is analyzed by the infrared meibography, however, we did not really know in the disease images in like that, like it is really a gland loss or it is some kind of malfunction, or not the malfunction, but it is some kind of problem with the imaging modalities. Like when the inflammation or dry eye disease causes the thick conjunctiva on the top of Meibomian gland, and the infrared imaging cannot have so much ability to penetrate all of this thick conjunctiva. In that cases, OCT has the ability to image deeper into the tissue compared to the infrared meibography, and therefore we believe the three-dimensional OCT images could give me more intensive method to detect the Meibomian glands. Here is an example of the cross-section of the OCT, and we develop a software to segment the layer of the conjunctiva into two layers, like the epithelium layer and subepithelium layer. If you see, this is the from blue to green, it is a epithelium layer, and green to red is a subepithelium layer, and the dot arrow is the cross-section of the Meibomian glands. And on the very right, you could see a three-dimensional structure of the Meibomian gland. This is these three dotted, even the arrow, these three glands are presented in here. I don't know if possible, I could see. Yeah, so this is the three-dimensional view where you could see really a gland loss happens in the inflammation or dry eye disease, or this is a false negative information from the infrared. Same as the OCT used in the Meibomian gland imaging, we further proceed it to the conjunctival blood vessels imaging. So far we know the OCT angiography used for the posterior segment, such as the retinal disease and age-related macular degeneration or retinal vascular disease. However, we want to try these state-of-the-art imaging modalities to image the conjunctival blood vessels, and we believe that it would provide us a very high correlation between the healthy and OGVHD patients. So we collected some preliminary results. So here we could see the limbus areas imaging using the OCT. And this is the healthy images, and right hand side you could see the images of the OGVHD patient, and from the visual you could see a very high densely vessels and the very thickened vessels in the OGVHD patients. And we developed a software to differentiate between the healthy and OGVHD patients, and from the preliminary result you could see from the results that the vessel density and esclerotinite density and the fractal is much more higher than the healthy patients. So in summary, we could say that we have already developed a deep neural network based on Meibomian gland segmentation and quantification algorithm. We have published our result in on conference in Berlin, and we have already published our manuscripts. For in vivo confocal microscopy, we have developed two artificial intelligence networks for detecting corneal nerves and dendritic cells and further quantification, and we have presented our results in ARVO and EuDES conference, and our manuscript is under revision in TVST. And for optical coherence tomography, we have developed two preliminary softwares for processing eyelid conjunctival layer and 3D visualization of the Meibomian gland. And we also develop a software for conjunctival blood vessel segmentation and quantification. However, we need to further study on the optical coherence tomography images. So in the future perspective, we would like to build a very user-friendly softwares and a very high tools that could be benefited by clinicians in the hospitals. And the software tools need to be validated using the clinical data. So far, we collect the data, but it is not validated further. That why we have a plan to validate this software using the clinical data. And we try to acquire the CE certification to use the software clinically, and we want to commercialize of these softwares. And we also try to implement this software in the commercially available devices. So we already communicate with Heidelberg Engineering to implement the dendritic cells and corneal nerves into their HRT-RCM3 devices. And if possible, after the validation, we could distribute the softwares into our research consortium for the image analysis. From there, I would very briefly tell about my career transition. I just started a new position at the University Hospital of Cologne, which is under the hood of the Uniclinic Cologne, and it is the Research Institute of Center for Molecular Medicine, and it is the lab of data science of bioimages. So it's our new group is focused not only but also focused all on biological and image analysis such as cancer and other disease like kidney. So I am really looking forward my new position in here. And furthermore, I also try to collaborate with my PhD supervisor, Professor Steven, and new supervisor, Professor Bozek, and we are really try to establish a further collaboration and working on the eye area and the eye domain, and we try to move further and make a very novel established AI in the ocular surface. So, and I really want to thank you for my supervisor, Professor Philip Steven, Gwen Musial, Uta, and my industrial supervisor, Stephen and Ronald, all of their support and to this journey. And I also want to thank all of you of the IT-DED3 Consortium, one of my colleagues and supervisors. And thank you so much for your attention, and I'm really happy to receive your questions.
So thank you, Asif, for your presentation. So do we have some questions in the audience? No questions, or I will ask you some of them, because we are using the IVCM in, I mean, not me, but in clinics we are analyzing some images, and also in mice. And sometimes it's very difficult to identify the nerves and the immune cells. So when you are able to identify or to be sure that the cells you are detecting in the software, how you select the images, because sometimes the immune cells are close to the nerves. So are you sure you trace or you eliminate the very difficult images, or?
Yeah, it needs to be validated, like how it is performed in the very poor quality or images, or if the very immune cells is really close to the nerves. But if the dendritic cells are presented in the IVCM images, if it is close to nerve or not, it will be segmented. So from the software point of view, it will be segmented the dendritic cells. If it is there, so it would be segmented. No, it is no problem for the quality, or it is close to the nerve, or if it is on the top of the nerve, then still our software could detect the the dendritic cells.
And in your opinion, how you will be able to analyze the microneuroma? I mean, this kind of shape, or do you have any idea? Or?
Yes. So when I collected the dendritic cells images from the hospitals, around 800, I saw in the microneuromas in couple of hundreds images, but yeah, there's the future project. Maybe in the future we could collaborate and work to identify the microneuromas, like the how many microneuromas are presented in the images, their perimeter, their shape. So we could do that in the future, but so far we only work on the corneal nerves and the dendritic cells.
And do you think we can use the software in the cornea for the image obtained from mice or rat, or I mean for the preclinical studies?
I'm not sure because it is not validated on the mice, but I think me and Gwen also work on develop some AI tools to segment the mice corneal lymphatic vessels and blood vessels. So in the future, maybe we could validate in your models.
Okay, and when you segment the immune cells, you have immature, you have mature cells, and some people in the literatures count the number of dendrites or that kind of things. Do you think it's something relevant or?
Yeah, for my software, we already count the number of the dendrites because when we make a differentiate between the immature and the transition stage, then we make a boundary how many dendrites are presented on the cells. Like we not only put the threshold of the length, like 50 micrometer, then we put another threshold how many number of the dendrites like branches are presented on the cells. Like if it is more than 2, then it is like has branches, then we consider it is the transition stage cells, same as the mature stage cells. So we have count the length and how many number of dendrites over there.
Okay.
Yeah.
Thank you for your presentation, and we were talking about this during the coffee break. I was wondering if is it possible to reconstitute in 3D these dendritic cells to be sure that it's dendritic cells? Is it possible?
Yeah, is it possible? Yeah. Because from the from the HRT RCM, it is provide the stack of the images. Though we collect only the like slice, so we use only 2D. Maybe in the future we could use the 3-dimensional AI model to predict the dendritic cells into the stack on the volume of the images.
But you didn't perform this
No,
yet.
we didn't perform it yet. But it is possible. You need to manually annotate the dendritic cells in a volume of the stacks. Then we train the model to detect the dendritic cells in the volume. Then we could perform the segmentation in the volume.
So hopefully in the future.
Yeah, in the future, yes.
Congratulations, Asif. Can you go back on the images of the vessel with the angio-CT? You have very nice images. Yes. Yes, or those images. I have been working on the vessels with angio-CT from the very beginning of angio-CT. At the time, it was just developed for the retina, and then we could use it for the anterior segment and especially for the conjunctiva. And I was, from the very beginning, surprised by the very, very high density in vessels we can observe compared to what we observe with slit lamp, for example, and same volume or same surface, we have a lot of blood vessels. Yes. This is a good example. Yeah. And the answer is in fact based on the principle of the angio-CT. I'm not sure everybody is aware of the angio-CT technology. Because what we are observing is based on the movement. Angio-CT is a system where all structures that are in movement are transformed into white colors or white lines or pixels, and it's not based on the staining. It's not based on reflectivity like in confocal microscopy. It's based on movement, which means that what we are observing are those structures moving after a series of OCT. In the retina, when we observe something moving, it's obviously a blood vessel. There is no other structures. But here you have the combination of blood vessels and lymphatic vessels.
Yes.
Because they are moving, but the lymphatic vessels are transparent at the slit lamp.
Yeah.
And this is the explanation. So it's fascinating to observe such images because we know that we are, for the first time, without any intervention or invasive methodology, we are looking at the lymphatic vessel. The problem is that I am still unable, and probably everybody is unable to differentiate the two.
Yeah,
By confocal microscopy, it's possible to differentiate lymphatics from blood vessels. The shape and the speed of the element inside are different. Sometimes the inflammatory cells move in one side or the other side. It's very, very interesting, and the future will be probably maybe based on the flow to differentiate lymphatic vessel from blood vessel. But it's very, very interesting.
Yeah. Yeah, because this is an example from Heidelberg Engineering. They are trying to produce the Angina OCT, but which is quality is not good because they are in the trial phase to develop some kind of Angina OCT. So we have a clinical device which is Canon Exfolia. We get it for 3 months in our hospitals. Professor Steven get it to this. We tried first to image only using the Canon, but at the first we didn't get a very high quality of images. Then we use extra optics on the top of the lens. Then we get some kind of good quality of the images. But however, the device is only there for 3 months, so we cannot get enough data for validation of our software. So maybe we are hoping in the future we could do that again.
Yeah, thank you. It's very nice pictures. If you go back on the Heidelberg, in the Heidelberg, or just the horizontal lines, in fact correspond to the micro movement of the eye.
Yes, micro movement of the eye.
And it's very, very difficult because the most companies don't develop specific software for compensation.
Exactly.
Unless in the retina they have developed eye tracking system to try to decrease the micro movement.
Yes.
So it's much better. But so it's very difficult to get
that's true.
very good images.
Yeah.
So I think it's time to end the session. So I would like to thank the 3 speakers, Murat, Asif, and Adrian. Thank you again.